Are you sick and tired of the high costs and inefficiency plaguing our US healthcare system? Do you feel like you're navigating a maze when dealing with insurance companies, only to end up paying a fortune for basic medical services? Then this Broken Healthcare podcast is for you. So get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live, ladies and gentlemen. Welcome to Broken Healthcare. My name is Ray Kober. I am your host, and we are joined today by Michael Fine, MD, or is it Dr. Michael Fine? I'm always confused. Do you want the doctor before, or do you want the MD after? How do you do it?
Just don't call me late for dinner.
Excellent. Well, thank you so much for joining. We had our paths crossed, or at least we breathed the same air in a room down in Washington, D.C. back in December at Rosetta Fest. And what were you doing down there?
I was there speaking, actually.
Oh, really?
Yeah, speaking about a book called On Medicine as Colonialism.
On this book.
On that book in particular.
I am in the throes of this work of mastery that you put together. It's interesting. I definitely want to get into the book. So, what was your impression of Rosetta Fest? Was it your first time there?
It was my first time. I know Dave Chase a little bit, but I was thrilled to see what I was seeing. I have been involved in all sorts of healthcare in a zillion different ways for a long time. But I spent some time in the mid 2000s starting a DPC like network in Rhode Island, one of the very early DPC experiments. And I spent the whole time trying to figure out how to find an employer or how to find an insurer who would provide high deductible major medical that we could couple with what's now called direct primary care.
Huh.
And to see this energy and this work on these basic ideas was exhilarating.
It's remarkable, isn't it? So, for folks that don't know, Rosetta Fest was spawned out of something called Health Rosetta. Dave Chase is one of the co-founders of Health Rosetta, and he was an originator at Microsoft. He led up their healthcare team. Basically, they had a unit, and Dave headed that up. And so he now shifted gears and is involved in really, I think, doing incredible work with shining a light on what's wrong in healthcare, what we could do about it, and bridging the gap between service providers, physicians, employers, um, uh, in the insurance industry, benefits brokers and advisors, and really imagining or reimagining healthcare, if you will. And so your participation in an event like that is incredible. It's wonderful. And your book on medicine as colonialism, it's eye-opening. And I definitely want to dive into that and unpack that a little bit. So what gave you the idea that this was a work that you wanted to write? Is it something that was kind of brewing for a while? Were you thinking about this, or was bam, where you're like, you know what, I'm going to sit down and I'm just going to do this thing?
I got mad. I mean, it was during the pandemic,
Mm,
and there's a whole long story that I don't want to do the whole thing here, but I actually I worked in the, and I still work in the poorest, most densely populated, most diverse city in Rhode Island,
mm,
Central Falls, Rhode Island. And we were the most COVID infected place in the state, in the nation, and for periods of time in the world.
wow.
We were desperate to get resources. And those resources didn't come from the state, even though the state got $1 billion of money from the federal government.
Mm,
But we created an amazing volunteer process to help people who didn't have primary care doctors get the counseling and the testing and the triage and food and disinfectants, the things people needed
Mm.
to get through the pandemic. It was an all volunteer process. And then, as soon as we asked for a little support, we started seeing these interesting young people from the Midwest show up on our Zooms, because we did a lot of the organizing on Zoom. These interesting young people show up. We didn't know who they were or where they came from. We knew that they weren't Spanish speaking, and we knew that they certainly didn't know anything about public health, but they started advising us. Who were they? It turned out they were consultants, highly paid consultants from all sorts of very famous national consulting groups, and they were getting paid. They ended up in the first couple of months of the pandemic, the state paid consultants $12.7 million and wasn't really sending much in the way of resources to its most infected place. And so I said, "What is going on here?" Um, and
That's
that's when
bizarre.
it sort of the light went off in my brain that what I call healthcare has nothing to do with the public's health and everything to do with profit and wealth extraction. And then I began to just sort of track down each segment of the healthcare economy and look at how that works, and found out not only were my suspicions true, but they were 100 times worse than I ever thought.
So was this your first foray into this experiment where it was kind of the COVID epidemic that was the catalyst that lit the fuse, ignited the spark that sent you down this road, or had you spent some time looking at the inequities in healthcare prior to this?
Oh, I had sort of devoted my whole professional life to this.
Ah,
Um, I'm a family physician by training. Uh, I cut my teeth. I was in the National Health Service Corps, and they sent me to the mountains of East Tennessee, where I saw it close up and personal for the first time in the fifth poorest county in the United States.
mm,
Um, and so and there was a situation there. Two doctors who rented the local hospital from the county for $1 a year, and then would kind of capture people, drain them of their money, and then take them to court in this incredibly poor place. And they each had these these beautiful farms of 7,000 acres each, with purebred herds of purebred cattle. And there it was kind of laid out for me that way, that time,
wow.
that healthcare wasn't always about, the care of people in communities. To some people, it was a way to make a bunch of money. And
That
so
sounds that
I
it sounds like, truth is stranger than fiction. That sounds like a movie, but a horror movie. It sounds maybe like a wonderful fairy tale for some of the people that cashed out, but, my god, like, really? Like, literally, this is what was going on?
yeah, and to me, I was just shocked. I sort of went there because they sent me there,
Right.
and trying to unfold it became really quite challenging. And so much of the rest of my professional life has been about thinking about and doing these kinds of things. And then, I started a large private practice in Rhode Island, and then, we actually helped with the beginning of the direct primary care movement.
Michael, I'm sorry to interrupt, but
Yeah, yeah, yeah.
you gotta unpack that for me a little bit.
Sure, sure, sure.
I wanna go back to rural Tennessee. Where who were the profiteers? Were they docs?
Yeah,
They were doctors, like
they
local
were
doctors,
doctors.
and they set out to provide care in a poverty-stricken community, and then when folks couldn't pay their bills, went after them financially?
Yeah. I mean, I'm not sure what they set out to do, but
Right.
they found themselves there. It was kind of nobody else was looking over their shoulder, and somehow they figured out how to make this all work.
Wow.
The people in the county, it took basically an hour to get anyplace else. And you had to go over a mountain like you wouldn't believe.
Right.
I mean, getting into that county was near impossible. I mean, you could do it, but it took a lot.
Yeah.
Um, and so it was really isolated. And so
They were the only
most
game in town.
it
They had
was
they had a monopoly.
absolutely the only game in town.
Yeah.
People had no other place to go and no other source of information because, to make it worse, in those years, the county was about 66% illiterate.
Wow.
This was in the mid 80s. Um, and, that's kind of the scenario that these guys started with. I got sent in to work in the county health department. Um, you know, I was innocent of everything. I thought I'd just go and see patients. And then, this thing started to unwind. I looked at getting privileges at that little hospital, and you don't want to know what I saw. I mean, it was like they were doing maternity care, they were delivering babies. They had no operating room and they had no lab. Um, and so, if a woman in labor got into trouble, all they could really do was call the helicopter, which is kind of what they did.
Wow.
And so we had one of the highest infant mortality rates in the country. Um, I can go on and on and on about the character of the practice, which was scary.
Yeah.
But built onto that character of the practice was this obvious wealth extraction,
Mm.
where they pay close attention to, like how much money people had, and they put them in the hospital usually for no reason, and they'd keep them there till their estimate of their money ran out, and then they'd because nobody had insurance, and then they'd kick them out of the hospital, and then they were the judges of the county court. So when somebody got taken to court, they were also the people who decided what happened. It was quite a deal.
My God. Yeah, and again, you can't make this stuff up. Like that is the definition of the word predatory.
Yeah, predatory when it was local, and then when you take it and expand it and look at how that happens across the country, you
Yeah.
begin to see how we're being predatory or cannibalizing our own communities using healthcare as the umbrella. Because what happened in Hancock County happens in the rest of the country. If a doctor who is trained and experienced tells you that you got to do this or you're going to die, most of the time you're going to sort of listen. And that gives the healthcare world a very unusual advantage in terms of, pushing people to do stuff they might not otherwise do.
Of course, people trust their doctors, and the other piece of this though is I don't know that it's readily apparent how this decimates the lives of people. And it's not just the patient, it's the people that are connected to that patient and the ripple effect that it has. And that's what really intrigued me about, your book as I read through it. It's this concept of colonialism never really occurred to me. It's kind of an abstract term. It's one that's not really used. It's not in vogue anymore.
Right.
But the idea that the very hospitals that were funded with public dollars are now being acquired by private equity and by folks with deep pockets. And then they're turning around and driving these hospitals into the ground and selling them off for the sum of their parts. That's our money.
Yeah, well, that's the point. It was all donated money, and hospitals. Almost nobody knows this data, so nobody knows that 65 to 70% of all hospital income is Medicare, Medicaid, and public employee. Right.
Right.
So all hospitals are running on public dollars, and yet, when was the last time you ever heard anybody on a hospital board elected? Essentially, hospital boards are self-appointed, self-governing, and there's nobody in charge. Nobody's sort of looking at this. I
Yeah.
had been in government, in state government, and I kind of knew how the regulatory process worked. And I didn't see anybody who had any significant regulatory authority to intervene. Even me, when I was in government and had, some kinds of authority, but not this kind, which
Mm.
is the kind of authority that I really would have needed.
Yeah. So there's really no checks and balances. It's kind of like the Wild West.
Yeah, and we have the regular people, sometimes they call it civilians, have the notion that there's somebody kind of thinking about all this stuff and being in charge, and being in control and being in control. And what you begin to realize when you start, sort of interrogating it or lifting up the hood is that nobody's in charge.
Yeah.
Nobody's in control, and nobody's there making sure that, we spend public money in a way that gets us the best public health outcomes at the lowest cost.
Mm.
And because nobody's in charge of that, everybody does what they want, which is make money. This is a market, not a system, and it does what we want markets to do, which is generate profit.
Unbelievable. And true. So when I look at what you said earlier about the part of Rhode Island that you were in, and it was one of the poorest counties, if not the poorest, neighborhood
City,
city,
poorest city in the state.
poorest city in the state. Um, as someone who's not a doctor from the outside looking in, I would say, well, they're impacted more so than the rest of the population because for a bunch of reasons, right? They're not educated. They don't have access to PPE equipment. They're more apt to spread it from person to person because
Population is densely packed, and
densely packed.
densely packed populations spread infectious diseases.
Right.
People during the pandemic had to go out to work every day because they were considered essential workers. But for that, that meant they were going to work construction or work in a factory.
Right.
And it was factories and meatpacking plants and fish houses,
Right.
where people work closely together. That's where the disease got spread.
Of course, and think about it. These people don't have the luxury of a savings, account backing them up. They're living paycheck to paycheck, and they're going to drag their asses to work no matter what condition they're in.
Because they got, particularly if they're undocumented, they kind of have no choice. They're
They have
always
no choice.
on
Of
the run a
course.
little bit. And it's like there were lots of people who are in better circumstances who could work from home or, lived in a 5-bedroom house and there were 3 people living there so they could spread out, not in Central Falls. Almost like 10% of the population could work from home.
Right.
So, like they were a setup. The population of Central Falls were a setup for this kind of spread of disease. And this whole process where, their wealth is extracted, they don't have much wealth.
Yeah.
And so when what they've got is removed, they just don't have much left.
Right. Right. And, not to mention the fact that the mortality rate of people that were obese and people that kind of fit the demographic of these poorer communities because they're eating whatever food they can afford to buy, and unfortunately the most readily available food supply is highly processed crap that that kind of fuels the fire of their disease and diabetes and obesity, et
And
cetera. Stress,
stress
right?
itself, right?
And these are the
Living
folks
close to a pack, et
that were
cetera.
really impacted by COVID. What did you see on the front lines of this thing? Were a lot of these people dying?
Well, I can talk about the statistics in a minute.
Yeah.
We knew that the disease was in Central Falls because, in some of the work we had done together, we had developed a close relationship with EMS.
Mm,
And I found, I carried the title of the chief health strategist for the city of Central Falls.
yeah.
And I was working closely with EMS and folks from EMS in March of 2020 said, we've seen 4 or 5 deaths of young people who we found dead in their houses.
Oh,
And then when we took them to the hospital, then they tested them and found out it was COVID.
wow.
So that's how we learned about it. There were too many young people who died. We did a bunch of things to intervene to try to stop that. And that volunteer process was one of those things. So
Mhm.
we ended up with a crude death rate that was about average for the state. But I think about average in the most infected place in the state, nation, in the world. I think about an average death rate was a huge success.
Yeah. Oh, sure. No question about it. It was absolutely devastating. It was the darkest period that I can remember being alive. I'm 58 years old now, been around for a while, and I don't remember ever like, there was the Vietnam War. I was a kid, didn't really impact me. There were some wars here and there. Didn't go through World War II, didn't go through a plague, that sort of thing. But COVID was a really dark time in this country, at least from my perspective. And it seems that an awful lot. Look, we responded and we got out of it, thank God. But it seems to me that there's definitely some level of manipulation and profiteering that is it's really disgusting that you know if for folks to have profited um off of COVID the way that they did, it's it just talk about angry, it really is infuriating.
For folks to profit off healthcare is
Correct.
just, I mean, that, the profiting in COVID when we had a national emergency was
Yeah.
particularly painful. But I
Mm,
grew up with an ethic that said, you shall not profit off someone else's misfortune.
mm,
That is a major societal, uh, you know, sort of a major societal ethic, because once people start uh, profiting off each other's misfortune, then there's actually an incentive to cause that misfortune.
mm.
And then we create a society at war with itself. And
Yeah.
that's the thing that we must not do, and yet we're doing every day. And I wonder about the extent to which that ethos has pervaded the society and caused some of the perception of partisanship and rancor, because we've decided that it's important. I mean, that it's okay for people to profit off one another's hardship.
Yeah, no doubt. And look, and this is not. I've said this multiple times on the podcast. It's not an indictment against physicians and people that the men and the women that dedicated their lives to the profession, but the profession. Not the profession, but healthcare has really morphed into something quite different. And look, I am a freedom guy. I am a capitalist, and I make no bones about saying that I love capitalism. I think it's the bedrock of it's the foundational bedrock that this country was built on. The trouble that I have, though, kind of to your point, is profiteering off of someone else's um, misfortune is no way for a functional society to sustain itself. The market will correct; it will fix itself to an extent. But now we have healthcare systems, and you mentioned, and as I read through your book, so I have a very, very close family member that was in a position where her heart was beating. She was experiencing tachycardia. And so um, we went to a local cardiologist. They gave her a monitor to wear, and they were going to track this over, the course of a week or so. Well, before we made it through the course of a week or so, um, she had experienced like super tachycardia. She just taken a walk to a local grocery store. She felt like her heart was beating out of her chest, and so we took her to a hospital here on Long Island that's renowned as a heart hospital, and under the guise and the auspices of a charitable hospital, a nonprofit. We go in and they run some tests, ask a bunch of questions. She's not experiencing tachycardia while she's there. And they advise uh, that she should have a cardiac ablation. They do an EP study. And so, knowing what I know, I made some phone calls, and it was really not, hindsight is 2020. So had I known better questions to ask, I would have asked better questions. But it was really more about the medical scores of the physician and the practice. And the medical scores were off the charts wonderful. And so, long story short, she goes through we go through with the EP study. They do a meet with the physician afterwards. He said, they noticed this anomaly, this electrical short circuit that shouldn't have been taking place. And so they ablate the tissue, which is they destroyed the tissue.
Yeah.
And she leaves the procedure and she goes in an amazing, vibrant, confident young woman and comes out um, with someone who really had some anxiety issues. And
Yeah.
so my whole thing is, why not, as a first step, before going through with an ablation, why not recommend magnesium as just a daily supplement, and let's see how that goes. And so the answer came when I saw the EOB and the fact that the hospital billed over $180,000 for that procedure. And then on top of it, if you add up all the other junk, it was close to a $200,000 bill. And if this is going on, Dr. Fine, and we know it is going on, why I mean, come on. Like that's just not cool. Not right. It is something that really must be stopped. And look, now I'm going to play devil's advocate and I'll say what the doctor would probably say. Well, she's not having tachycardia anymore. You can't say with certainty that the procedure didn't help. Okay, that's valid, but why have that be step number one? Why not, try something, a less invasive, like take a supplement and let's see how you do as a step number one, as opposed to putting a young lady through that. And, this hits home, getting back to my point. It's not just about the patient. It's the patient and it's the circle of people, the rings of folks that are connected to that patient. It affects more than just one life. And so, as I read through your book, that really jumped off the page because one of the things that you cited was one of the things that I had personal experience with. And every time I turn around, I'm like, what is the statute of limitations on this? And should we sue? And not for the money. I don't care about the money. But there are other people that are being funneled through this ER every day into that fucking EP lab, and they're suffering, and that's not cool.
Well, not only are they suffering, but their communities are being drained of the resources they need to do the things that might help control anxiety. In young women, tachycardia is often caused by anxiety, and I can't second guess this case, obviously, because
Of course.
I don't know the details, but the 200,000 or so dollars that was spent on this, what if we had used it to create a public park? Or what if we had used it to improve public transportation? Or what if we had used it to improve housing in a neighborhood that was rough so that people didn't have to be afraid? The point isn't just that this stuff is expensive. The point is that when we spend money on things we don't need, we don't spend money on the things we do need and turn out to matter for the public's health. And those things are, pretty much in order: education, housing, public transportation, and the environment. So we end up diverting, money that we should be spending on public and social programs to medical care that comes out mostly as profit and probably doesn't have much impact on the public's health. That's the real heartbreak.
This episode of Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today. The cost of a procedure like that is greatly inflated, right? So we are in a fully insured plan. My wife is a speech language pathologist. but we know that the true cost of that procedure should have been a fraction of that. Yet
Yeah, I mean,
that was the bill charge.
go in go go into have the same situation happen in most of Europe. Most people walk away without any bill at all, or,
Right,
150 bucks or something like that, because they've architected it in a totally different way.
right.
And it's when you begin to do international comparisons that you really begin to see the poignancy of our distress, which is profound. You
Yeah,
begin to see that other countries spend half as much as we spend,
yeah.
um, and have way better public health outcomes.
No doubt. I mean, we're the last time I checked, we're close to 20th in the world in terms of quality of healthcare, and by far we spend the most, and that's of Western industrialized nations. We rank very
Right.
low on the list, um, and there's
The lowest among those specific industrialized nations.
what
We're
is the
the
do you know, I don't wanna throw you under a bus or blindside you, but what is the pinnacle? Is there a country that does it right and you'd be like, "God, they have a system that we should emulate."
There are a couple.
Yeah,
Finland is particularly good.
yeah,
The Norwegian countries, I mean, the Scandinavian countries in general tend to do it pretty well.
right,
Uh, France does it well, Spain does it well, Costa Rica does it well.
right.
We strike out.
Yeah, if I'm not mistaken, um, Novartis is a Scandinavian company, and they manufacture Ozempic,
Right.
and, they, if I'm not mistaken, don't allow it to be prescribed
That wouldn't
in their own
surprise me.
country,
I
right?
think the
So
country the company that makes it is in Norway, if my memory is right.
Norway, okay. Yeah, so, yeah, but it just goes to show you, it's like the manufacturer of the drug is in your home country, and yet I don't know if it's never or illegal, but it's not often prescribed.
And that's going off at what, 1,100 bucks a month, something like that?
Oh, 1,100, 1,500, whatever the PBM could get away with.
Yeah. The problem is it's endless, and the challenge is not just to admire the problem, but find a way to change it. And that's the big challenge at the end of the day.
Yeah. Well, I love the concept of direct primary care, value-based care, because it turns things upside down. So in a traditional healthcare setting, you have a physician that may be responsible for 2,000, 3,000 patients, which is just absurd. And in a direct primary care setting, typically it's sub 500 or thereabouts.
3 to
And
500.
right, and so you now have the ability to, without the stress and the pressure of a traditional healthcare system where you're bogged down with paperwork and a ton of red tape, you actually get to put hands on your patient and spend time getting to know your patient. And the patient gets an experience that is quite different than in a traditional healthcare setting where, they're often, look, I'll use myself as, as an example. If I want to see my primary care physician in New York City, the earliest that they could see me is 6 months out, and,
Crazy.
then get that appointment, go wait in the waiting room for an hour and a half or 2 hours, and then they'll spend 15 odd minutes with you,
If you
write
get
you
that much.
write you a script and say, "It was good seeing you."
Right, right, right.
Well,
Whereas a DPC physician, you probably have their cell phone number, and you can talk about stuff, and if they need you to come in, they're likely to spend an hour with you.
right. So, describe that a little bit more for our audience. Is this available to the general public? Are you forced to go through an employer channel? And with a DPC provider, what is your safety net? If God forbid lightning strikes and you are diagnosed with stage 4 cancer or some other dread disease, do you have an insurance policy backing you up?
Well, everybody does it a little bit differently. And that's, so it's hard to speak for everyone in the entire universe of DPC physicians. I'm
Yeah.
not one, so I know about it, but I'm not expert because I don't do it myself. But I believe it's available to people in the places where there are DPC physicians. There are 2 to 3 thousand across the country, um, which means of maybe 250,000 practicing primary care people. So it's a tiny drop in the bucket, and those practices tend to fill up fast. So available conceptually, but practically sometimes more, sometimes less, depending on location. And most DPC practices um, want to have their only relationship being with the patient, not with an insurance company, not with
Mm.
Medicare, not with Medicaid. So by and large, they don't take Medicare or Medicaid. By and large, they don't take insurance. And by and large, they're paid for by a monthly subscription. It ranges between $60 and about $150 a month. So that means some people can afford it, and unfortunately, some people can't.
Mm.
The other major rate limiting step is just the number of clinicians we have in the country doing primary care, which is a huge and major challenge that most people haven't yet plumbed the depths of. Depths of. We are probably short 200 to 300,000 primary care clinicians in the United States today.
Oof.
And people perceive that shortage just getting sort of regular old primary care. You can't find a primary care doctor in most places. Takes you 6 months or a year or 2 years to get in, etc. But that's compounded in the DPC world, where people limit their practices to 3 to 500. Now,
Wow.
in terms of your question about uh, sort of what happens if you get a dread disease, um, DPC practices, like all primary care, do primary care, which means they don't do orthopedics, and they don't do oncology. They would refer you to somebody else to manage those highly complicated and dangerous conditions. And for that, if you're being fiscally responsible, you're going to want to have insurance most of the time,
Right.
unless you're wealthy enough to self-insure for everyone. And there's only one Elon Musk.
I'm pretty sure there are a few other wealthy folks out there.
Yeah, yeah.
Yeah.
But I mean, I think there are relatively few of us. This is the 1% world. There are
Yeah.
relatively few of us who are financially comfortable enough to say, I can pay for anything that comes my way. So most of us want to have insurance for hospitalization or other expensive medical procedures should they happen
Right.
to need them. Remembering that insurance really exists to provide personal financial protection in case of illness or injury. It doesn't provide health care. It
Right.
provides personal financial protection.
Of
And
course.
that's what people need.
Yeah, I mean, the real purpose of insurance is to protect against catastrophic financial loss, and so insurance is morphed into something more than that, and where we're kind of being, oh, just boiled slowly on a stove like like a frog in a pot of water.
You better believe it.
heat is slowly being cranked up, and you're like, ah, this is pretty comfortable. This is nice.
Yeah,
Uh,
yeah, yeah. Though
you know what your
though
goose is cooked.
that comfort is costing families $25,000 per person per year at the end of the day.
Yeah,
Essentially a
yeah,
new car every year
sure.
is going to the cost of family health care.
Yeah, in New York City, Metro New York, Long Island, you can, if you had deep pockets and you were foolish enough, you could buy a platinum plan on the exchange for upwards of $70,000 a year for family coverage. That is
Great.
just an extraordinary amount of money. And so why wouldn't you think about maybe buying a catastrophic plan, something that, protected you in the event of, God forbid, catastrophe, um, and also layer in a direct primary care provider Because here's the other thing, and you could correct me if I'm wrong, but it seems that the the norm is for a patient to walk into an office, have a complaint, tell a doctor that he wants what he saw on TV. Can he write him a script for that? And, off he goes with the script, and that's it, on to the next. And shouldn't it be, let's do a thorough analysis of your blood work. Let's see what optimal is, and let's see where you are, not what the normal range bullshit is. Let's see what optimal is, and how do we get you to optimal, so that the goal is to get you on the path to actually being your best self, as opposed to trying to fix you when the wheels come off. Right.
Well, I mean, that's the brilliance and beauty of primary care.
Yeah.
One of the things that most people don't know is how actually inexpensive primary care is. Remember, we're talking about a per person per year spend of $15,000 in the
Mhm.
United States on average.
Yeah.
The average cost of primary care, DPC is a little more, but the average cost of primary care, 4.5 to 5% of that, or $500 to $600.
Mm.
500 to $600 is the cost of, like, your high speed internet in a month,
Right.
or some of the streaming things that people watch on TV. I don't
Right.
watch TV, so I don't really know that, but
Yeah.
um, but you get the idea.
Yeah.
If you break it down to $45 a month, it's something we all can afford, and yet all the value, the personal and public health value of healthcare, basically resides in the primary care piece,
Yeah.
doing that kind of prevention. You said, and I did this for years, so I kind of walk this walk and know it. You said, well, shouldn't we get a complete blood work and go from there? Most of the time, I would say we don't even need a complete blood work. What I need to do is listen to you,
Mm.
listen, sort of just sit and hear who you are, what you need, what you want, and what you're experiencing. And then we can work out ways of maintaining your health, which start with diet and exercise almost all the time.
Yeah.
The really simple stuff, making sure that you're sleeping and that you're not stressed, and your family relationships are good. I can't tell you how many times by listening I was able to say to somebody, "Gee whiz, have you thought of this? Gee whiz, have you thought of that? Gee whiz, sounds like you're stressed by trying to take care of your kids and your parents and running back and forth. Maybe try it a different way."
Mm.
And that different way made all the difference in how somebody felt. And I think most of us who do primary care and do it in a robust way, sort of start that way, not even with blood tests.
Yeah.
Blood tests once in 5 or 10 years, maybe, and particularly if there's a particular reason. But to sort of to just get a bunch of blood tests and try to chase those down, for most of us, doesn't even make sense, because a lot of what you see are kind of red herrings, and themselves take you down into a rabbit hole that you probably shouldn't want to. If you're feeling well, you don't want to go down.
Mm. Yeah, it's so my mom, God rest her soul, she passed in 1993 of malignant melanoma. She said,
Oh, I'm sorry.
if I go to the doctor, he's gonna find something wrong with
Right.
me."
Right. Right. Right.
And so, unfortunately, it was, it kind of came true. So she was bleeding from a place that she hadn't bled from in a very long time, and she had internal vaginal melanoma, and it turned out
Gee.
that it was, it had spread,
Yeah. Yeah.
metastasized.
Yeah. Yeah.
They interceded, but
It's
unfortunately,
a
they were too late,
it's
and
a very tough disease.
it is. And so I think there is something to be said, particularly, as we get older, because most disease kind of manifests later in life. We're mechanical creatures, things break down.
We
um
wear out. The
yeah.
body, the body is designed for 80 years, maybe 70 years. It's
Right.
not designed for 180.
Right. It becomes more important to at least go and get yourself checked out every once in a while. That's something that perhaps the outcome would have been different. I can't
Yeah.
say she'd be with us because she'd be 101 at this point.
Right, right, right.
But hey, you want to do what you can um, to be here and to be here well. No one's going to live forever. Let's face it. And
Right,
uh, you
right,
know,
right.
at, at the end of the day, I always one of my favorite scenes of movies. Doesn't sound like you watch much TV and movies. I don't know if we can get along, but
Whatever.
did you ever see Doc Hollywood with Michael
I
J.
did not.
Fox?
I did not.
Go and see Doc Hollywood. There. It's set in a little small town in the Midwest, and there's this old salty doctor who Michael J. Fox's character has to wake up in the middle of the night because some kid is having chest pains, and he's like, it's this, this, and this, and they fly in a helicopter. They're getting ready to take this kid off in a helicopter to a city hospital to crack his chest open, and this old doctor walks over in his bathrobe and his slippers. He pulls a can of Coke out of his pocket. He cracks it open. He gives it to the kid. The kid lets out a burp. How do you feel? Fine.
Fine.
That'll be 75 cents for the Coke because
Yeah,
that's what it
yeah, yeah.
cost back then. And
Yeah.
and that was that, right? And
And that kind
so
of stuff is common. I mean, if you do what I do, that I would end up doing that all day long.
right, right.
But it depends on knowing the family, on knowing the community, and
Yeah,
taking the time to listen.
right.
And what we've done as a culture is convert listening into diagnosis and treatment. Diagnosis and treatment is a tiny part of what we do. The most important thing in primary care is listening.
Yeah.
And that's what we've kind of taken away the opportunity for that to happen.
Yeah. No, agreed. It's just and I think the other issue that I see is the incredible prevalence of writing a prescription. And don't get me wrong, we've had some incredible, things, products, drugs come out of pharmaceutical companies. Uh, I'll be the first to say, there's a lot of good that, has come out of that. But I think it's far too common that the impulse is writing a script is going to get it done, as opposed to, let's look at what the root cause is. Why are you feeling anxious? To your point, stress, et cetera, et cetera. These are not solvable with, drugs and medication. And yet that's the impulse. I interviewed America's number one natural heart doctor, Dr. Jack Wolfson, and board certified MD cardiologist, and he's kind of done a 180, and he's not his go-to is not to write a script for a statin anymore. It's to tell a patient to get out in the sunshine and expose themselves to as much of their skin as possible, exposed to the sun on a regular basis. it's it's
Get
going
that
to
vitamin D conversion
get
going.
that vitamin D converted into good cholesterol, and every cell in your body needs cholesterol. But this idea, this notion that we now have this machine, this profiteering kind of mentality of write a script and send them off and the churn and burn, it's not getting us where we want to go. So that's kind of the doom and the gloom. What are you excited and optimistic about? Where do you see this going? Do you see a new crop of physicians coming up behind you that are not going to make the mistakes of kind of the old guard?
So I think it's about more than clinicians. I think it's about clinicians and communities. Um, what I'm excited about, I'm the president and board chair of a new organization called Primary Care for All Americans, that really is working in communities and with communities to make sure that uh, to sort of build a social movement, because that's what we think it's going to take, because
Mm,
of so much money, the money that's there trying to keep things the way they are. We think it's going to take a social movement to change things. And we think that social movement ought to start by providing primary care to everyone in every neighborhood and community.
Mm.
Now, that's a big lift. I mean, this is a 10 or 15 or 20-year process because we got to train a whole bunch more people. We got to get people paid fairly. We got to get communities involved with attracting and retaining people. You
Mm.
know, I mean, communities can do this for themselves. When we were talking in the beginning, I mentioned I was sitting in Situate, Rhode Island, which is the only place in the United States where everybody's guaranteed access to primary medical and dental care.
Mm.
But we proved communities can do it for themselves because we did. You at Rosetta Fest might have heard about Ashtabula, Ohio,
Hmm.
where they've put together a community-owned health plan. There are lots of things people can do in their own communities, but let me tell you, if you leave it to the healthcare profiteers, they're going to do what they are paid to do, which is make profit.
Sure.
Whereas if you think about primary care, what primary care costs is like the cost of fire and police protection or maintaining the roads. It's all at a level of cost that of things that the communities already provide for themselves, and we think we can help communities get there. That's what I'm excited about, and that's what we're trying to do together.
Right on. Michael Fine, MD, Dr. Michael Fine, however you want to say it. We really appreciate you joining us today. How do folks find you if they're interested? And this thing is available on Amazon, right? On
It
Medicine
is.
and Colonialism. Yeah,
Yep.
I'm giving you a shameless plug. I'm taking the shame off of you and putting it on me. But great read, fascinating, well done. One of the books that actually deserve being written. There's so many that aren't right now, but
Thank you for that.
very
Hey,
interesting.
so the two contact options are: first, Primary Care for All Americans is, not shockingly, www.primarycareforallamericans.org.
.org. Okay.
And then for myself personally, for the minute, I've written a bunch of books. It's www.michaelfinemd.com. And there are all sorts of resources there, or my email address, which is m1fine@aol.com, which just proves that I'm really old.
What? Still got that AOL
I
cooking,
still
huh?
got that AOL, and I like it. I like it way better than the other guy.
It works just as well as any other email address. Good
Indeed.
stuff. All right, doctor. Hey, thank you once again. Folks, until next time, we appreciate you. Peace and love. Peace and love. Take care.
So that's it for today's episode of Broken Healthcare. Head on over to iTunes or wherever you listen and subscribe to the show and join us on the next episode.